Same as him going, yeah, it's just. I mean, spells three. I didn't actually figure the name of the gun.
Different people. We haven't got to gatekeep him because he knows too much. Yeah, like he's just getting.
Kind of. Yeah. Well. Yes. My native weird.
She's like,
That's right.
I'm down there. You guys are up there. You guys never twice. We like. I was looking at you. I was looking up there and I was like, "Oh no, you're fish. Fish, like let's just make stuff that's easy. Fish and love it.
It's not such. I think it's all. It's not my song. It's
Fish. Did you look at it? It depends on the I really fish. No, like just because it's like. Oh my gosh. Yeah, somebody says I'm at the connection where your eyes no.
Oh.
Yeah, I was eating right next to me and they were so I'm like, you guys are actually trying to like she's saying I was in state, what do you go back first? There was some other it was that financial cost. That's something.
But I think
with now I'm so scared about it's all they
once it's on.
Yeah, it's like you
Like you get.
No. Because there was a time where it's like the pictures of the was, so there was one. So when you think this one, it's like these are all the same figure being different people, but there was one kind of thyroid cancer, there was one who just got like who was Tora. What's he always doing? People start I was saying thyroid cancer.
Someone actually.
Okay, you guys ready to go?
Because I was the one with the blood pressure or the blood sugars.
Okay, if you guys can't hear me, raise your hand. Got a little bit of feedback on that, so I want to make sure that everybody can hear. So quick question, who got really good sleep last night? But I'm glad you did because good sleep is good and helpful for good test taking. So how do you all feel about your test this morning? You go okay? Cool. All right, so we are going to talk about sleep today. Morning is another chance. Make a difference, touch a heart, encourage a mind, inspire a soul, and enjoy the day. Every day is a new day. Here are the learning objectives. So we're going to look at our 24-hour sleep cycle. We're going to look at mechanisms that regulate sleep, the stages of sleep, some of the functions of sleep, what happens when we don't have good sleep, and what we can do as nurses to help promote good sleep for our patients. So physiology of sleep. We have circadian rhythms, which is that biological rhythm of sleep that synchronizes our sleep. It synchronizes with our other bodily functions. So when your body starts to go to sleep, things like your GI tract kind of slows down, so you don't really a bit at night. When you wake up, that might kick back in. Your alertness will be different throughout the day, depending on your circadian rhythm. Times that are best for exercising, the times that are best for maybe a little afternoon snooze. All of those things are synchronized within your circadian rhythms. Your sleep is regulated by those physiological states that are integrated within your central nervous system activity. So your hypothalamus plays a big part in your sleep regulation. The reticular activating system has a part in your sleep regulation, as well as the bulbar synchronizing region. So reticular activating system, I can refer to as RAS, and the bulbar synchronizing region of the PSR. Okay, so the RAS, that reticular activating system, it is located in the upper brainstem. It helps you to maintain your alertness and wakefulness. This system is receiving those visual, auditory, tactile, all of those sensory stimuli. It releases catecholamines such as norepinephrine when it is stimulated. And as you are trying to fall asleep, that stimuli is going to decrease, and your BSR is going to take over. So the RAS is the thing that helps you be alert and wakeful. So the BSR, the bulbar synchronizing regions, when you're trying to go to sleep, they're going to take over. They're going to release serotonin, and they're in that system of on the medulla. It's going to control your sleep. Also, so melatonin plays a big part in sleep. It's secreted from the pineal gland, and it controls the body's circadian rhythm. So when it starts to get dark at night, that is going to stimulate the release of melatonin. And then as the light comes in the morning, then that starts to suppress so that you become wakeful again. So what do you think would interrupt the secretion of melatonin? Light screens. So what activities do we often do that would disrupt that? Scrolling. Actually, doom scrolling. Anything that's got that blue light is going to really interfere with melatonin, which is really hard because we have the lights on at night, we're studying, we're scrolling. So be mindful of that as you're trying to get good sleep. One of the ways that we can increase our sleep hygiene and ability to sleep better is to just shut everything down screen wise at least an hour before you want to go to sleep. So here are the stages of the adult sleep cycle. There are basically two phases of sleep. There's the non-rapid eye movement in REM, and the rapid eye movement, the REM. So the non-rapid eye movement has 4 stages, and then the REM cycle is the phase at the end of each sleep cycle. Yeah, so a typical night's sleep, people will pass through 4 to 6 complete sleep cycles. So they look kind of like this. So that non-REM, with the 4 different stages. So it'll go 1, which is kind of that getting sleepy, going to sleep stage, and then it'll go 2, 3, 4, 3 to a REM cycle, and then it will repeat. So we'll go through 4 to 6 of those cycles. So here's another kind of graph of what a typical night's sleep would look like. So those stages, the 3 to 4 of the non-REM, those are like the deepest sleep. So we have a few of those, and then we'll have the REM sleep. And it moves in and out of that. The hypnagogic phase is also called the pre-cycle or pre-sleep cycle. So that's when that person's getting sleepy. Normally it can last 10 to 30 minutes, but sometimes it can take up to an hour to fall asleep. So that's stage 1, right? We're just falling asleep. Your heart rate is going to slow down a little bit. Your muscles are going to relax. That myoclonic jerk often occurs. So you ever had that happen where you're just about to fall asleep and your body like jerks you awake? That's a myoclonic jerk. So as you're falling asleep, those are some of the things that can happen. And then in the stages, stage 1 and 2 are the latter stages of sleep. And the sleeper is easily aroused at this time. So when you have noises, will bring you out of that. Stages 3 and 4, those are the deeper stages of sleep, and it's more difficult to wake up during those stages. During REM sleep, it's possible to have vivid, full-colored dreams. This usually begins about 90 minutes after your sleep has begun. So your heart rate, blood pressure, and respiratory rates are going to fluctuate at this time. And again, it's very difficult to arouse the sleeper. So what are the functions and benefits of sleep? Sleep does a lot of things for healing in our bodies. It releases growth hormones and assists with healing. So protein synthesis and cell division are working really hard to renew your tissues, your bone marrow, your gastric mucosa, your brain. All of these are healing during rest and sleep. So we need good sleep for good health. Another benefit of sleep is that it preserves our cardiac function. As our heart rate decreases, it helps our heart kind of relax and sustain the function. It also helps with our energy conservation as well as our energy levels. Another benefit of sleep is cognitive restoration. So it's going to change how our blood is flowing through our brain. So we're going to get that increased cortisol activity. We're going to get increased oxygen consumption. Epinephrine is getting released. It helps with memory storage and learning. So again, as students, we need that good sleep so we can remember all the things. And our brain filters all the information about the day's activities. Rest contributes to mental relaxation, freedom from anxiety. It helps with our mental, physical, and spiritual activity. One thing to note, especially with our patients, is that bed rest does not guarantee that a patient will feel rested. Some of the things that affect sleep are physical illness. So hypertension, respiratory issues, musculoskeletal issues, chronic illness, GI issues. All of those can contribute to poor sleep. Sometimes our lifestyles contribute to poor sleep, our work schedules. I don't know if any of you are on the shift work, but like the 12-hour shifts of nursing can affect your sleep. Especially if you're working the night shift, that will definitely impact your sleep. So just be aware and figure out ways that you can promote good sleep. So blackout curtains are helpful. Headphones or, earbuds or anything that can block out the noise. All of those things can help. Exercise is good for you for sleep. As long as you don't overdo it. We went hiking last week in the mountains, and I'm still hurting. So my calves are like ramping up, and that was definitely affecting. We have to be mindful of how much exercise, how fatigued we are. But some exercise is good. There are some drugs and substances that do affect sleep. Definitely like alcohol and caffeine are going to affect your sleep. Part of the social lives might affect our sleep. And then food can also affect our sleep. So like a bedtime snack is good as long as it's kind of light. But a full meal right before you're going to try to go to sleep is not going to help with sleeping. So some of the things that correlate with an adequate amount of sleep. So if your patient is not getting enough sleep, it can contribute to feelings of confusion and suspicion. Actually see this quite a bit, especially in older adults in the hospitals. They'll get confused about where they are and what's going on. Inadequate sleep can alter your mood. It can alter your equilibrium. It can alter how you're moving. It alters your memory. It can do crazy things to your immune system. So if you're not getting enough sleep, your body doesn't have what it needs to fight off illnesses. And it also, lack of sleep contributes to traffic, home, and work-related accidents. Physical illness is one of the things that can contribute to a lack of sleep. So any pain, discomfort, anxiety, depression, any of these sleep disturbances can affect sleep. Things like respiratory disorders. If you have trouble breathing, it is really hard to get good sleep. Nocturia, if you have to get up and use the restroom several times a night, that can also contribute to poor sleep. And then pain, of course, is one that we see a lot in the hospital. And another thing is restless leg syndrome. So this is a CNS disorder. And it's this need to move your legs when you're trying to go to sleep, which disrupts sleep and is kind of a common thing, especially in older women struggle with this a lot. So some of the sleep disorders that we commonly see are insomnia. So just that difficulty falling asleep, or you'll wake up, you'll go to sleep, wake up in the middle of the night and not be able to go back to sleep. Sleep apnea is most commonly an obstructive thing that keeps you from sleeping. So you'll be breathing, but then you'll stop breathing for a second. That will wake you up, and this can happen a lot during sleep. Narcolepsy is a sleep disorder where people will just fall asleep at kind of inappropriate times during the day. Sleep deprivation can be caused by emotional stress. Some medications can cause you to have wakefulness, environmental disturbances and symptoms. And then parasomnias are more common in children, but it's like sleepwalking, night terrors, nightmares, nocturnal enuresis, just bedwetting, body rocking. Insomnia may have some of these symptoms. So excessive daytime sleepiness, and it might be caused by physical or psychological problems such as situational stress. Can be caused by medications. So the way to treat insomnia is to treat the underlying emotional medical problem. One of these ways we can improve sleep, hygiene measures, and make sure that the environment is quiet and dark. Try some relaxation techniques like a warm bath, maybe a little massage, get some muscles relax. Listen to some quiet music. Sleep apnea. So those are periods greater than 10 seconds of not breathing. Obstructive sleep apnea is the most common. So what that is when the muscles of the throat and the oral cavity relax, but then they close off so you can't breathe. So people who have sleep apnea will often snore very loudly, and this is but you'll see that it's the body trying to sleep, right? So or trying to breathe. But the snoring is trying to. All right, again, those symptoms of sleep apnea, excessive daytime sleepiness is the biggest one. And they might wake up hundreds of times each hour. So that's something to consider with people who have sleep apnea. They might be going to sleep, but they're not staying asleep, and it's disrupting their ability to sleep. So one of the ways that we can assess if somebody has sleep apnea is the stop bang scoring model. So these are questions you can ask your patients. Are they snoring a lot? Are they tired? Are they exhausted during the day? Do they feel drowsy during the day? Has anyone observed them stop breathing while they're sleeping? Do they have increased blood pressure? So are they taking medications for hypertension? Is their BMI greater than 35 kilograms? Are they over 50? Is their neck circumference more than 40 centimeters? That can to maybe get some kind of treatment. So treatment for sleep apnea would be lifestyle changes. So weight loss. A lot of times with excess weight kind of up and around that neck area, it can obstruct the airway. Sometimes it's tonsils and adenoids are causing an obstruction in that airway, so that they can remove those. The most common one I see is the CPAP machine, which is a continuous positive airway pressure. It's worn at night. It's a mask over their nose, and it holds the airway open, so the air pressure holds that airway open, so that it's not collapsing and causing any constriction in that. Narcolepsy is another sleep disorder. The person suddenly falls asleep during the day at uncontrollable and at inappropriate times. Normally, a person will take about 45 minutes to get into REM sleep, but for people who have narcolepsy, they can have REM sleep within 15 minutes. It can cause kind of this confusion about what's real and what's dream, just because it happens so quickly. I had a church member once who fell asleep just in the middle of the sermon all the time, and I didn't know until the pastor of the church told me that he had narcolepsy, and it was the strangest thing because I thought he was just being rude, and that is common misconception that people are being rude or inappropriate, but they have a sleep disorder. So there are some treatments for narcolepsy. Sometimes antidepressants can help, or CNS stimulant. Modafinil is one of the most common ones that are used. And it is going to improve wakefulness. And it's a Schedule IV drug because of the potential for misuse. So you want to be careful with those medications. All right, so parasomnia, sleep disorders. This is the one that's more common in children than adults. It includes the problems such as SIDS. So they think that SIDS is one of these sleep disorders, and so for infants, you want them to sleep on their back to help prevent that from happening. Sleepwalking is common. Night terrors, nightmares, nocturnal enuresis, and tooth grinding. So the treatment for these depends on the condition. Again, so sleep deprivation, some of the causes are illness, emotional stress, medications, environmental disturbances, shift work. We talked a little bit about that. And the symptoms are confusion, agitation, decreased auditory and visual alertness, decreased reflections, and increased sensitivity. Some of the medications that affect sleep are hypnotics. So those are gonna help you go to sleep. Diuretics. Those are the medications that are taking fluids off your body. You want to give those in the morning. Sorry.
For the ones that disorders that maybe affect kids, once they get older, do they just grow out of them? Or do they have them for like the rest of their life?
I think it depends. A lot of times they grow out of them. But yeah. I would say most of them grow out of them. And then if you have a concern, it's always good to speak with your doctor, right? Question.
Good question. Okay, so we just went over sleep deprivation. I know that when you're an inpatient in the hospital, you get woken up all the time. Machines, nurses coming in, people coming in to bring you food, the guy next door making noise. Are we giving our patients sleep disturbance or sleep disorders?
Potentially, yeah. For the duration of their stay. Yeah, and that's one of the things that we'll talk about a little bit. But yeah, so think about what kinds of things you can do as nurses to help improve sleep. Okay, and put that in your head. We're gonna talk about that in just a little bit. It's a great question, and yes, we can in the hospital absolutely contribute to people's sleep disturbances. Diuretics. So diuretics, we want to give those kind of during the day, give them at night. Potentially your patients are going to be up, needing to go to the bathroom. So we don't want that for them. We want them to be able to sleep. Some antidepressants can cause sleep disturbances. Some actually make you more sleepy. So they might be important for those as well. Alcohol is one of those things that like kind of feel sleepy, and then you go to sleep and it will wake you up and keep you awake. Caffeine is something that you want to consider time of day and the amounts. Beta blockers can affect sleep. Benzodiazepines can help with sleep, but are habit forming, so you don't want to take those long term. Narcotics, can also affect sleep. It can make you sleepy. And then anticonvulsants. Depending on your age, will depend on how much sleep you need. So neonates are going to sleep for 16 hours a day. Infants will sleep 8 to 10 hours at night for a total of 15 hours per day. Toddlers are going to need 12 hours. During total preschoolers are going to need 12 hours at night. School age kids sleep 9 to 10 hours. Adolescents are getting less than 7.5 hours of sleep. But they need sleep for their brains to like continue to grow and learn. Gotta encourage that. And then young adults, they're gonna get somewhere between 6 and 8.5 hours. And as you get older, your sleep is going to decline. Yeah.
So obviously sleep's important. We have a whole class on it. Just wondering, how do you guys keep track of that or qualify that in the nursing division?
How do we qualify sleep?
Yeah, so I mean, you could say, oh, he slept 8 hours tonight, but his watch said that he actually only got 1 REM cycle.
Yeah, so I currently work during the day, so I'm not sure how they do that at night. But I worked for a while, I worked in an acute treatment unit for mental health crisis, and sleep was one of the things that we really tried to track. And staff would do 15-minute checks on the patients while they were there for safety. But also we were trying to monitor their sleep. So it was kind of this was balance, right? Of not disturbing their sleep, but monitoring it and making sure that they were safe. And there was a big conversation. Like staff would be documenting that they're sleeping, and then they would say, I didn't get sleep last night. And so you always want to listen to what the patient is saying. Their perception of their own sleep and rest is the most important thing, right? Because we can say you got 8 hours of sleep, but if you're not feeling rested, there's a disconnect there. So we need to help our patients, and help figure out how to help them get better sleep. So that was definitely a conversation we had in that setting, making sure that we were helping people get sleep. So yeah, there's sometimes there's like the disconnect between what we might be observing and what people are experiencing. Did that answer your question?
Yeah, I guess what I was trying to say was I think if we monitored their sleep, we're able to have a better idea with that data. We could make some other decisions to help steer in the right direction faster.
Absolutely. So as people get as adults get older, sometimes our sleep gets more disruptive and we get less sleep as we get older. So be mindful of that. Some people don't need as much sleep, and some people are just not getting it. So as nurses and looking at that nursing process, right, we're going to assess how our patients are sleeping, right? We're going to ask them questions. How, what is their sleep history? How are they sleeping? What problems might they be having with sleep? What is their usual sleep pattern? We're going to be looking at any physical illness, any psychological illness, maybe their current life events. Maybe they have a newborn at home. They're just not getting a lot of sleep at night. Or, maybe they're in school and they're studying for tests. We're going to be asking about emotional mental status and then bedtime routines. Because how we prepare for sleep is going to affect how we sleep. And then our nursing priorities, some of the things that we're going to be looking for in the patients, are they feeling anxious? Are they having trouble breathing? Are they confused? Do they have maybe some compromised family coping or ineffective coping with life stresses right now? Are they experiencing insomnia, fatigue, sleep deprivation? Are they preparing themselves for a good night's sleep? So are they scrolling in bed, or are they shutting all those things off? As nurses, we're gonna implement health position, right? We're gonna be looking at the environment and what is maybe contributing to good sleep and what might be distracting from good sleep. We're gonna be educating about bedtime routines, gonna be promoting safety. So for our patients who are in the hospital, we might want a little bit of a light so that they can find the bathroom and make sure the area is clear. So that if they're moving to the bathroom, they don't want them to trip. This is also true at home. You want to make sure you have a clear path. We're going to be making sure that our patients are comfortable. Is the room too hot? Is it too cold? Did they have too many blankets on? Do they not have enough blankets? Are they uncomfortable in their positioning? We're going to be looking at periods of rest and sleep. A good 20-minute nap in the afternoon is great for your brain. Any longer than that can disrupt sleep at night. We're going to be educating about stress reduction, those bedtime snacks that will light meal, maybe, or light snack, maybe cheese or milk, anything with tryptophan, like a small amount is good for sleep. We might be looking at pharmacological approaches for dealing with sleep issues. So what kinds of things, coming back to that, what kinds of things sleep routines? Okay, what can we do? What are some of the things that distract or interrupt sleep? And then what can nurses do about it? I'll let you guys kind of brainstorm some ideas. What are some of the things that might distract you if they're not in maybe an inpatient hospital setting? You mentioned some earlier.
Don't bother them as much. I mean, cluster, whatever you have to do. So if you have to go in and do 2 or 3 things, try to get those done all at once. That way you're not coming in to take blood pressure, not coming in again to check something else. Get it done one.
Okay, so suggestion here is to cluster care. You put your hand up? Oh, you took your thing. Okay, cluster care. Yep. So if you know you're gonna have to do vitals and medications and all the things, just try to get them all done at once so that you don't interrupt sleep as often. What other things can we do to help good sleep? Lights up. Turn the lights up. Yeah, there are options.
We can have a quiet time on the floor. So shut the radio off at the nursing station. You know, let these people sleep.
Quiet time on the floor. So what about talking in the hallways?
Be mindful of your voice level,
Exactly,
volume level.
exactly. So maybe have a conversation somewhere else at the nurse's station rather than next to a patient's room. We can close the door. One feedback we got recently is that they were cleaning a room at 10 o'clock at night. So maybe we can manage that a little bit better. Time wise, I think that was like a shared room and they were cleaning half of it and another patient was trying to sleep. So just being mindful of when what's going on in the environment to help our patients sleep. Yeah, those are all great ideas. Anything else? Yeah, so we're looking at environmental controls. We're going to be looking at promoting comfort, getting those periods of rest and sleep, safety, stress reduction, controlling those physiological disturbances, and then pharmacological approaches. So we also want to be like managing patients' pain, right? Or any of the things that might be disrupting their sleep. If they need more oxygen, That might be another. So, and then in that nursing process, we're gonna be evaluating, right, the patient outcomes. So were the patient goals met? Are they able to fall asleep within 20 minutes? Then you want to know how well they're sleeping, maybe when they exercise. Did quiet music help? Do you feel rested when you wake up? So these are questions that we want to be asking our patients. What's helping? And how are they sleeping? That's you. But, any other thoughts, questions, comments? About sleep.
Okay, so you know, like when you wake up or somebody wakes up or your alarm goes off, and then you fall asleep right after it's news or whatever. I feel like that's the deepest sleep. So my question is, when you return to sleep, does it restart or do you just return to the cycle, or part of the cycle that you were
That you were
already
in?
in? Yeah,
Well, that's a question.
I think you return to
I
it, right?
think,
Because when you wake up after the alarm goes off, those are vivid dreams and you wake up. That's a vivid dream, you know?
yeah, you might be going like not quite wakefulness, but then coming back to that. Like, because our sleep, remember how our sleep cycle kind of goes,
Yeah.
like, you're more awake and less, so yeah.
And people talk about how getting 6 hours is better than getting 9 because of just the timing and the part of the sleep cycle that you wake up in. So I
Yeah,
think that it doesn't really start.
yeah, I think that sleep cycles, you definitely kind of want to get through a full cycle, because if you're awakened out of a deep sleep, that your brain hasn't had time to do all of the things to recover that it does in the deep sleep, and it just kind of, yeah. So get it. And that's one of the things, like there are sleep apps and watches and stuff that kind of help with that. So you can kind of, I don't know, it's just me, but you can kind of see where your sleep cycle is and how, what the time is for you to get the best sleep and how long for you. You can kind of use the technology, which is really cool, to find out what's best for you for sleep.
Yeah, I was gonna say, after babysitting for so long, the white noise machine started to really affect a quality of sleep for me that was better. Just as another
The
device.
white noise machine helps with sleep.
Yes,
Yeah.
yeah, help me.
Yeah, because it kind of just keeps a consistent level of sound that,
And I became conditioned, like every time it is down for nap, okay.
Yeah.
I hear that, I'm ready to.
Good question, like, so you have, all different like ages of patients on your floor. They're all on different sleep schedules. I know people in my family that like to get up in the middle of the night, 4 AM and crank the TV up. It's go time for them. So how do you kind of manage those different sleep schedules on the floor? Because some people are up like at night. They like to be up at night, and like some patients would like to be sleeping at night. They don't want to be disturbed.
I think most people are pretty aware, like in the hospital, at least in the hospital setting, they're aware that other people are trying to sleep. So they're pretty quiet, at least in my experience. When I work nights, again, at the acute treatment unit, we did have people who were kind of up in the middle of the night, and they were quiet and respectful for the most part. They weren't, yeah, so we just allowed them to do, quiet activities.
Yeah, maybe you could offer them to walk around the unit
Yeah.
if they're able to. I don't know, I've never worked with a shared room, so that
Yeah,
is definitely.
yeah, most people don't really have the TVs on. I might just, kind of turn the volumes down for that, but yeah. I think, yeah, again, I think most people are pretty respectful of the fact that but yeah, allow them to walk if they're quiet. Stuff. most, I said most, people. We've got always the exception, but.
You could also like initiate a different intervention, like here's a puzzle or something, coloring book, here's a book. Like remind them that there is another patient in that room.
Yeah,
But
yeah,
yeah, they're kind of crazy. Hopefully they have their own room.
we, fortunately, we only have one shared room on my unit.
We don't have any.
Thank you, guys.
Thank you.
We will just power through with the, so let's make it 10 minutes. Then we'll power through with skin and wounds. We'll be back at 12:55.
Oh, yeah, good. Actually. You just. So.
Weird.
Yeah. I think.
Don't throw things away.
I'm still in the, regular.
Oh,
So this girl took these choices, okay?
In, I was like, but you know.
What else did we do? Can we upload our content map to the not in there? Yes. Okay, cool. Anything that you uploaded. Hey, you guys like to do it twice so why? Because I have to go back and grade all those things or acknowledge all those things. If it just hasn't been graded yet, you're okay. If it's there, you're fine. I just haven't gotten to it. Yes.
What did you say?
Yeah.
You misplaced them, you should grade. Hey, so the next time I'm ready to read supposed. What happens? Actually, I don't think that we'll have the same problem because you'll be in a master now and then baby now. So. Thinking with you, why is the skin important? So I have some obvious ones up here, but what are some other reasons why the skin is important besides here? Besides largest organ in the body. These are cheater pants ones because these are from like Patho A and P. What are other reasons why the skin is important?
Thermal regulation.
Okay, I like it. What else? It holds us together. I like it. Keeps all the wet and gooey stuff inside. I like it. I can express myself creatively. Yes. Yes. Tells you something about me. Like it. On that note, what else about that? What else does that do though? Psychosocial aspect of it, right? It tells you something about me. Crazy. What? Think about that. If you have somebody who has, say, a massive burn and has disfigurement, that really impacts that person, right? Not only does that impact that person from a psychosocial aspect, it impacts them. They struggle to synthesize vitamin D. They struggle with pain. They struggle with temperature regulation. They can have either hypersensitive areas or hyposensitive areas, where they don't actually know where they are in space, in their physical space, because of how their skin is interacting with the rest of the world. So our skin holds this wide variety of very important regulations with us and the rest of the known world that we live, right? So reminding us from A and P, the skin is composed of two layers, epidermis and dermis. And within that, you do not need to memorize all the different sections of it. You had to do that for A and B, not necessary for here, just understand dermis and epidermis. When it comes to nursing though, nursing is critical when it comes to assessing and monitoring skin integrity. I want to know, is that person's skin intact when they come to see me? Is it all put together? We want to identify, do they have actual problems or do they have potential problems with their skin? Do they have that This is the tiniest, frailest, most tissue thin skin of the 95-year-old person that comes in and you just like brush a Kleenex against them and their skin's just gonna fall right off? Or is this somebody who has worked outside and their skin is tough and man, you're gonna be lucky if you can get a chainsaw through it because they're just that rough and tumble kind of person, right? So then we have to have in our mind, what interventions am I going to do to maintain the skin that they came in with, so they have that same skin or better when they go out. Because that skin is so vital in that protection from them and the outside world. Because all of that is keeping us away from what is trying to get in and invade us. There was a trigger warning on the very first page because there's some really ugly pictures as the first one comes up here. One of the biggest concerns we have is pressure injuries, pressure ulcers. This is any kind of injury that happens to skin or tissue from pressure. It can be in combination with shearing injuries or friction. So this is, when you're thinking of shearing or friction, you have those nasty rug burns. You know, you're playing on the floor with your kids or when you're little and your brother like slides you across the carpet. You're like, that's what happens when you drag a patient up in bed. Now, sometimes you don't see that actually on the surface of the skin. Sometimes that happens in between the dermis and epidermis. And it's actually shearing and friction in between the two layers. And then, because our patients are already at a heightened illness, injury, maybe they're dehydrated or they're sick with something else, this starts to manifest. And it may look okay from the outside, and then all of a sudden it starts to become this. So where are we most likely to see pressure ulcers occur? Okay, so we got the buttocks. Where else though? Bony prominences. So when we say that, what are we thinking of? What are bony prominences? Yeah, any place that we got bones that like to protrude, right? Hips, insides and outsides of ankles. Any place that likes here. Tops of the ears for people who wear glasses, hearing aids, oxygen. Right? So we want to be thinking about all those places that have potential for skin breakdown. And then for any contributing factors that lead to tissue ischemia and tissue death, what are we concerned with for our patients? Obviously them having pressure on us, right? That's a problem. But what else can lead to our patients having the potential for this?
Mobility.
Immobility, all right. Lack of protein. Are these people like our specimen of health and wellness? No, these are people who are already at risk, right? We're talking people who have some kind of underlying medical diagnoses, probably. They're generally fighting kind of infection. These are not people who are your specimen of health and wellness. So you're just like, yes, look at this beautiful, healthy person, right? My brother had a liver transplant. He's a year from his transplant as of July 8th. Super amazing.
He had pressure ulcers across his lower back and buttocks because he spent a year being unable to move. Mostly because of just complete physical exhaustion, but he also had a huge belly filled with ascites, going for infusions for albumin and for drains of his ascites. He was 40. A guy. He would never have thought that he would have an abscess on his back and have a pressure ulcer on his back. Because he could get up, he could move, he could do the things. So nobody thought to do an assessment of his backside until his third admission to the hospital. And those nurses came in, I'll tell you what, you want to know a thorough nurse? Is those tiny little Filipino nurses. Those nurses will strip you down, put you on a turntable, and they're lifting up buttocks, they're pulling you apart, they're lifting the cheeks, I'm telling you, they are something, every Filipino nurse, they are the most thorough nurses I have ever met.
Funny side note, I was talking to, he was from like the middle of nowhere Philippines. And so over there, they're able to work in a much higher capacity than they do over here. And so they are used to like, being very, very responsive.
Oh, yeah.
Their patients.
I think that that's probably why they are on it. Anyways, so that was this nurse and she came in and she's like, sir, how long has it been like this? And she probably was 60 if she was a day. And he goes, I don't even know what you're talking about. And she goes, wound care is coming in and dealing with this. Thank goodness, because he had a pressure ulcer that started to look, it wasn't quite that bad. It's not the brown in the middle. But she helped and made it to where he started he didn't start to heal until after he got his liver, but he didn't know because he really couldn't feel it. But he also wasn't going to show his sister. He just, anyway, so think about, it's not just your patient who is this immobile, in bed, can't do anything. Patients are at risk for skin breakdown, regardless of what they look like, regardless of how they appear. Pay attention. So here's some common bony prominences. The chin, if your patient has to wear a C-collar, any place that C-collar is resting against, so you can get skin breakdown all across the clavicle and the chin. So think about what that looks like. Any place that you would want to move if it starts to rest on something too long and you don't think to move it because you can't feel it or you can't move it. So if somebody is in a wheelchair, if they have diabetic nephropathy or other types of diabetic neuropathy, there we go, thank you. Think about them not being able to feel it and not being able to move. So risk factors include impaired sensory perception. So why can they not feel it? They had a stroke, they have neuropathy. Altered level of consciousness. Why do they have altered level of consciousness? What's going on with them? Impaired mobility. So these are all things that could possibly be wrong with the patient. Shearing, friction, and moisture, we absolutely have control over. What can we do to prevent that? Number one, if your patient is incontinent, you have all the power to be cleaning them as much as possible, cleaning and drying them as much as possible. Whether we're using a Purewick, whether we're changing them as often as we can, whatever we're doing to keep them as dry as possible. When it comes to friction and shearing, ensuring that we are actually lifting that person up and moving them in bed instead of just like sliding them. But also talking to them about when they are moving. Because if your patient is just kind of sliding themselves in bed, they need the education on how that is not good for them, because they don't understand that even them doing that with their weight can cause that shearing and friction. So we want to make sure that we're educating them on that. Part of what that wonderful Filipino nurse did was she talked to my brother about how he couldn't roll over in bed without truly lifting his bottom up and twisting and turning, as opposed to just sliding in the bed. So that was part of what was causing the skin breakdown. So how does it get so bad? Part of this is, what is that pressure intensity? How long is that pressure there? And what does that tissue tolerance have? So thinking about that really strong, burly guy who comes in, or woman, maybe it's one of these amazing construction workers that we have that are out there. And maybe they fall and break something, have no. I am not going to be as concerned for that person and their ability to maintain their tissue integrity as I am for that sweet 95-year-old who has had just the tissue thin skin, right? Who fell and broke something and has to have surgery. Because their tissue tolerance is much, much less. The injury that happens to the capillaries that are underneath there are going to be damaged so much more quickly by just the slightest amount of pressure. Because that protective layer of subcutaneous fat is missing. So we get that microcirculation injury a lot quicker. We get the capillary occlusions a lot quicker, which leads to tissue ischemia, cellular death. We end up with having more damage quicker than a person who's a little fluffier, has a little bit more oomph to them. And what is that pressure intensity? How much is being exerted on that? Is it just my arm resting here versus my entire body resting on my backside? That's more pressure on that. Is it my entire body on my backside for 12 hours versus my arm resting on here for 10 minutes? So it takes this combination of, I don't want to say a perfect storm because it's a moderate storm to have skin breakdown. It happens entirely too quickly. So the first things that we look for is blanching versus non-blanching. And we want to know, blanching is good. If the skin still blanches, we still have tissue perfusion happening. Once we start to have non-blanching skin is when we start to get really concerned. So one way you can check is, it's just the same way that we check for cap refill is, did we blanch or not? So you can just look, am I getting blanching back? So we call it something special because it's not really capillary refill when you're checking on other parts of the skin. So you notice there's an area that you're concerned with. It could be reddened, it may not be. So you check, are we blanching versus non-blanching? So is it red? And when I check it, does it turn white and then turn back to the red? So both long and short-term times of when a patient is immobile or resting on a bony prominence can cause damage. And it doesn't take that long to cause damage. For a diabetic who has neuropathy, they could put a sock on in the morning and have just the right pressure from a seam up against a toe, walk on it for that part of the day and start to notice that maybe not that it even hurts, but that it feels weird. It can be just enough pressure to start to cause an ulceration and already start to cause damage enough that because of their compromised, their body being compromised by diabetes, that they could potentially lose that toe. Because the delivery of oxygen, nutrients, and if they're having any trouble controlling blood glucose, it could increase their healing time and then ultimately have them need to have that toe removed. The ability of the tissue and the skin to actually endure the pressure is part of what we look at when we're talking about skin integrity. So how healthy is that skin? Are we talking about somebody who is a D1 athlete? Are they somebody who is very muscular, has subcutaneous fat? Are they able to withstand being sedentary for a little while? Has there been any shear, friction, or moisture present? We can tolerate that to a tiny extent, but once you start having injury upon injury upon injury, the body can no longer tolerate that, especially if there's unhealthy structures underneath. And then can blood vessels and collagen assist with redistributing any of that pressure? So our body attempts to help to redistribute pressure when we have areas that are taking on more pressure. So think about when you are sitting and you realize, ooh, that is really uncomfortable, but you're not really in a place to be able to move. Or maybe you're standing holding something and you're like, ugh, I really can't move right now because if I drop this, I'll drop the entire box and it'll land on my foot, right? But you know that thing is pressing really hard on your nuts or whatever, right? And so during that time, there is the potential for that to still cause damage to wherever that pressure is. But in that moment, the body is able to redistribute to a certain point. So you're still getting circulation. It may be causing pain, which is the body's way of saying, hey, this is a problem. But the body's whole intention is to maintain homeostasis. So it's going to attempt to redistribute a little bit. In somebody who is not healthy, they're fighting the infection, disease process, that sort of thing. They are not able to do that very effectively or for very long. So keep that in mind. So what do we do? How do we help with our patients? Number one, eliminate shear, friction, and moisture whenever possible. Most of this is education with our patients. Help keep the skin dry as much as we possibly can. Proper nutrition and adequate hydration. Our patients need, in order to have our skin intact, we need proper nutrition and hydration. We need to have protein. We need to have fluids. Otherwise, our skin gets dry and makes it more brittle. And then we need to recognize that older patients and patients with a low blood pressure may not tolerate generalized pressure. So if you already are struggling with a low blood pressure, any extra pressure on bony prominences, low blood pressure cannot accommodate perfusing that area. Does that make sense? The body's just gonna be like, well, hey, that area is just not gonna get blood from me right now because I gotta perfuse other areas. So repositioning, ensuring that everything's nice and padded for those bony prominences is gonna be really important. For pressure ulcers, they are staged 1 through 4. I believe you guys need to know this for 302 as well, so you probably should just kind of commit what these are to memory. And I think you might even need to know these for med surg 1. However, of note, I believe the Joint Commission has made it to where it's only wound ostomy nurses that do the staging. Is that how it is where you work?
Yeah.
So we recognize as nurses, hey, there is a need for wound care to come see the patient. And we can request the wound care nurse to come see them, but who's actually staging, doing the staging and then identifying it is somebody with a wound ostomy nurse certification. Yes.
Would you say it would be appropriate to document, like, rather than staging it and saying it's a stage 3, we can say like, there's loss of visible fat.
You would document, you would describe it, yes. You would describe what it looks like. Correct, yes. So you'd say intact skin approximately, I mean, I think even so much as measuring it. Lots of places with their EHR will have the camera ability to take a picture of it. But wound care comes in and they do a full, and then you're also documenting that you have requested wound care. So. And then here's examples of them. So intact skin, non-blanchable. And then keep in mind that our darker skinned darkly pigmented skin may not have visible blanching, but we have color changes from surrounding area. So it is important to recognize that it does look different when you have differently pigmented skin. Stage 2 is partially involving the dermis, where you have some loss there. With ulceration, it generally is not having any sloughing. It can be an intact or open blister. So, and then stage 3, we have full thickness tissue loss. Subcutaneous fat may be visible, but bone, tendon, or muscle are not exposed with stage 3. And then stage 4 is full thickness tissue loss with exposed tendon or muscle. And often we see tunneling with stage 4, and you can't see tunneling and undermining with stage 3. Then there's unstageable, where you have full thickness tissue loss. If there is too much eschar, that brown, black, tan, and it can be really thick, almost leather-like in the wound bed, that is unstageable until they have it. Which that patient, depending on the size, may need to go to the OR for it because it's incredibly, it can be very painful. So prevention is the most important aspect of this. We do not want to have your patient end up with any of these. They are preventable. I should say length of stay is what LOS is. So length of stay and cost of healthcare in general increases with a patient who has a pressure ulcer. So if your patient comes in with a pressure ulcer, identifying it upon admission is very, very important. Which is why the wonderful Filipino nurse came in and was lifting and prodding and moving everything on my brother. Made me feel like a terrible at-home nurse for not knowing about it, but you know what? She, by identifying that and knowing that he came from home with that, it saved the hospital from any issues down the road, saying it was pre-existing, it was not a problem that developed while he was there. CMS does not reimburse if that patient developed a pressure ulcer while that patient was staying in the facility, particularly stage 3 and 4. But if they developed while the patient was there and it progresses, they will not pay for that entire stay regardless of why they came in the first place. Yes.
On admission, one of the first things we do is put a methylex right on that behind bony prominence, and then, yeah. Which is helpful,
Preventative.
helpful for prevention. Yeah, it's like you have to do that.
Well, and so many people, especially if they're critically ill, will end up losing weight or they third space, and you end up with like all of this excess fluid, which doesn't make things any better. But it's also costly to patients. It causes disability and pain and suffering. These are not comfortable. They are incredibly painful. Based on where they are, depends on the type of pain. But if you have pain, like a big sacral wound like that, imagine laying down, sleeping, sitting. Any position that you're in is going to be impacted by that wound. So I cannot even imagine how awful that would be. So assessment and documentation are going to be huge for any patient that's coming to you. Assess for signs and symptoms of any sort of development, both visually and touching, because sometimes you can touch an area and it feels, the word we use is boggy, which sounds like a strange word, but it's like when you're touching along here and it feels meaty, right? You're touching your arm, it feels meaty. Touching your thigh, it feels meaty. When you touch, has everybody had a blister in your life? And you know how it feels like watery? You've all touched your blister, I know you have. Even if you don't want to admit it in public, touch your blister. How it feels watery? That's what it starts to feel like underneath as it starts to develop. Like it's boggy. It like a water balloon in another way. Like, but it's under the skin. It doesn't feel like the rest of the muscles surrounding it. And it might just be a little area and you're like, that doesn't feel right. So pay attention to that. Pay attention to things that are underneath casts, underneath other devices, slings. If you have somebody who is in a, like if they have to have a clamshell for spinal surgery, if they have a C-collar or they have a halo on, any of those places where things, devices are touching them, why do they have sheepskin all underneath them? Because they may be places that they're hitting bony prominences. If you note any places of redness, yes.
How does the reimbursement work in long term? The same.
I'm not sure about long term but it is a huge problem if they develop. Yeah, because long term is they live there, but they generally. I'm not sure how that works for long term. I have to look that up. Yeah, I know it's for acute care. They won't do it for it, but. Yeah. So if you note any redness, note the location, size, color, reposition the patient if at all possible, and then reassess in an hour, and then make sure you're checking for blanching. And then done. Okay, And then we want to, most places are using the Braden score to check for the patient's risk for developing a pressure ulcer. The lower the score, the higher the risk. The score is anywhere from 6 to 23. And here is our risk assessment. So we go off of sensory perception, moisture, activity, mobility, nutrition, and friction and shear. So you can see if you had all fours, you'd be perfect. Sitting here, although I don't know, sitting in chairs for as long as you guys do, I think that mobility, you might be very limited on some days, given, given your time here. And nutrition might be probably inadequate if you're surviving on junk food and caffeine. So I guess it depends on what we would say your brain scores are. Activity, I guess activity would be chair fast, given, depending on the day. So, well, you'd have to evaluate what your brain scores would be. Like you're in a wheelchair, like bed bound, chair bound. Chair bound, you guys. Nothing that a little duct tape won't help. I'd be careful because I did remember to record today. This is forever out there that I'll duct tape you guys to a chair. Okay, wounds. Talk about wounds. Whoever did this to that person. This is back when we had to do the sketch on level fronts, right? Yeah. What? Oh, it didn't happen to my son's hand. It happened to his leg in elementary school. Oh, my kid was bonkers. Not my son, just had a stab at him. Okay, so wounds are any disruption of integrity and function of the tissues, including the skin. And etiology is any way that you can possibly disrupt the skin. So we can have, surgical incision. We can have a tearing when you're like clawed at by a bear. Yes. Let's see. I was trying to think of like something. You can have a loss of tissue where tissue has actually been removed from the area. The bear would probably remove some tissue if they did that. Or little or no loss of tissue, like with a nice clean surgical incision. Although with surgical incisions, if they're doing an excision of a tumor, there's going to be a loss of tissue. So we have a clean wound, which would be free from microorganisms. So this is something that would happen in surgery. We love that. Specifically in this case, they give the example of a heart surgery. There is a clean contaminated wound, which would be non-significant contamination with less than 6 hours elapsing until medical care. So this example that they use here is biliary and gastric surgeries, because the gut filled with all sorts of contaminations. The goal is that they cut out what they need to cut out, they clean everything up, and they sew it all back together, but it's still dirty. It's dirty in there, so we're gonna clean it up. Contaminated, without local infection and more than 6 hours elapsing until medical care. On the example that it uses here is colon surgeries. Again, the gut, gross, has stuff in it, but we're gonna clean it up, get it out. And then infected, an intense inflammatory reaction and frank infectious process. So think about appendicitis or cholecystitis when the gallbladder is very, very mad and angry and is infected, and we eat that right on out of it. So how do we classify the wounds? Well, based on the status of the skin integrity, the cause of the wound, the severity or extent of the injury, the cleanliness of the wound, and then we use qualities of the wound tissue such as color. Shallow wounds are just a loss of the epidermis and possible partial loss of the dermis. So think about your scrape, just little minor cut when you're kind of like chopping onions and you just cut yourself, right? Those are going to heal by regeneration. We do need the three components of healing: our inflammatory response, epithelial proliferation and migration, and then reestablishment of those epidermal layers. So that is our body working at replenishing what was there before. And depending on how long that takes is the size of the wound and how well that person is. So if you have somebody who has any kind of medical problems, if they are immune compromised at all, that may take longer. For both thickness wounds, that's going to involve the dermis, or the epidermis and the dermis, and heal by scar formation. This one has 4 phases involved: hemostasis, inflammatory response, the proliferation, and then maturity and remodeling. For surgical wound healing, we have primary and secondary intention. For A, that first one on top, the wound healing by primary intention is the wounds are healed together or pulled together and approximated either with sutures or staples. And the healing occurs just by connective tissue depositing. It's just coming together, and it's generally a fine scar. Wound healing by secondary intention is the wound edges are not approximated and it's just filling in. Epithelial cells are just filling into that scar tissue, and it is into that tissue. And the scar is generally much thicker and has more like granulation across it. So we have complications of wound healing. We worry about hemorrhage, which is generally it is excessive bleeding from a wound site. It can be normal, but we want to be able to stop it, right? Generally, it's just immediate after the initial trauma and stops with direct pressure. The hematoma is a localized collection of blood underneath the tissues. We could be super fancy and call our hematoma or bruise, the bruise, hematoma. And it depends on the extent of it, whether or not we're concerned. Infection, any wound infection, we do worry about initially, depending on how sick our patient is, what else they have going on. Wound infections are the second most common health care associated infection. The edges of the wound tend to be inflamed if there's drainage or if it's odorous, if it has purulent drainage, green, yellow, brown. That's when we start to be concerned with what our next steps are. A wound dehiscence is a partial or total separation of the wound layers. And any patient who's at risk for poor healing is at risk for dehiscence. So patients who are at risk for wound healing are those who are already sick with other things, who may have autoimmune diseases, may have they may be my brain is blanking. Sorry, guys. I'm trying to think of other things. Dehydration or protein intake. Yeah, I think I have other things too. Let's see, and then evisceration is total separation of the wound layers. and we generally see if organs are coming out. That requires immediate surgical intervention because we do not want organs outside of your body. And then here are some examples. So that one here is a dehiscence. So here is an evisceration. That one we have nice little correction. So other factors influencing pressure ulcers and wound healing. Nutrition. Nutrition is huge, and unfortunately with our patients, nutrition in the hospital is not great because patients don't necessarily want to eat. They don't feel good. And hospitals are not known for their gold star, A+, menu choices and food, right? I mean, people don't go like, yeah, let's go down to Parkview for dinner, right? I mean, we take up because St. Francis and Springs used to have cranberry Friday. And it was delicious, not gonna lie. And when I work Fridays, my husband would bring my kids to dinner Fridays. Because I'm rude. And it was like $9. It was delicious.
So were they in a dentist hospital at one point?
Catholic health officials.
Because of this, that's why people have been, it was like that. $5 and that was greatest meal.
Yeah, it's weird. Yeah. So I guess I just get back to school. And when Memorial North first opened, they used to have like snow crab legs on a night. It's like Sundays or something. So weird things, but that's changed. Okay, don't get all fancy. So nutrition is a huge deal because if you don't feel good, do you want to eat? Who's like, I want a 4-course meal of all the proteins and all the delicious things? No, nobody wants to eat when you don't feel good, right? Tissue perfusion is the proper nutrients getting to the place that needs it. That is a big issue. And then are we fighting infection? Are we fighting a generalized infection within the body versus where that wound is healing? Is there an infection there? If a patient has an ulcer, are they also fighting a systemic infection? The body is trying desperately to maintain homeostasis. It's trying so hard. And then the age of the patient, that makes a really big difference. Is it somebody who fell, broke their arm, and has a compound fracture? So they've got this massive wound on top of their fracture, and they were 25 and really healthy versus a 95-year-old who fell and broke something. Those ages make them, they have different problems going on. So maybe the 25-year-old was a smoker. It makes their healing very different than the 95-year-old who has diabetes and hypertension. When we inspect the wound, depending on what it looks like, is going to define our assessment. So, or guide our assessment. So when we look at an abrasion, maybe it's a little weepy, we've got maybe a little bit of bleeding, a little bit of plasma leakage, where it's just that little, okay, let's get this cleaned off. And you have to decide whether or not it's worth a Band-Aid because you're like, man, that's gonna pull off more hair than it's worth, right? Lacerations. Did I slice my hand open trying to open a stinking avocado? Does it need stitches or not? Is it gonna heal or is it gonna leave me a big scar because it's trying to do secondary healing? A puncture wound, if it has something still in it, do I leave it or try to take it out? Leave it. Leave it and stabilize it. And then surgical wounds, obviously, are going to depend on what the provider has ordered for for any kind of, like, any coverings or, bandaging, that kind of thing. But I want to be able to describe the amount, color, consistency, the odor of the drainage. That's all part of the wound, assessment. So if I have my friend who broke his arm falling off of his motorcycle, I could have the potential for all different types of wounds on this person. If he drove gravel all up his body and has road rash, then I may not end up doing anything to his abrasions except ensuring that they're clean and putting a topical antibiotic ointment on it. But I'm still gonna have to document what those abrasions look like. Maybe he has a laceration from hitting his chin on the handlebars. Well, we're gonna document that in any care that I do for that. When we are assessing wounds, we want to use the RETA assessment. So redness, edema, ecchymosis, drainage, and approximation. So that's looking for, is the area red? Is there any swelling associated with it? Any bruising? Is it having any drainage? And then if I have wound edges, how well are they approximated to each other? Are they coming together nicely? Or are they kind of all wonky and off to their side, right? So what's going on with that? When I inspect a wound, I look for any foreign bodies. So my friend who decided to slide down some asphalt off his motorcycle, I could be picking gravel out of his wound for days, right? Is that wound dirty? Absolutely. Is there anything embedded in that wound? Well, probably. It's not gonna like me too much by the time I'm done with them. What is the size, shape, and depth of that wound? Well, you're gonna have to do the best you can to describe it. Is my wound the size of a paper plate? Is it the size of a grapefruit? How can you describe that? And then does that patient need a tetanus shot? If they don't know when their last tetanus shot was, the answer is yes. Even if they got it a year ago, a month ago, and they don't remember, it doesn't hurt them to get another one, but it does hurt them to not get it. All right, wound appearance. Are the wound edges closed? Is it starting to come together? So look nice. Is the wound clean? Open, closed. These wounds, these are open. Not good. Don't like that. Is it sutured or stapled? If so, how many? You can tell. If you're going to describe it as appears infected, make sure you say why. It has purulent drainage. It smells odorific. Actually, not odorific, odorous. Just realized that in the live captioning, it said Pretty Little Liars when I said purulent drainage. It's like, that is very, very different. So now it's in purulent draining. It's not like purulent drainage. Is granulated tissue in the wound site. So granulated tissue is that pretty pinky red, nice, beautiful stuff that we want to start coming up, saying that yes, I am healing, I am beautiful, I am ready. Wound colors, no, these are icky. So black wound, yellow wound, red wound, mixed colored wound. Do you love how these are just, you're just describing what you're seeing. You're not being fancy with it. It is, this is a approximately fist size wound, yellow in the center, with purplish red reddened area around it to approximate cantaloupe size. I mean, I'm not in the room with that patient. So you would describe exactly what you see. I mean, in this case, it looks like that might have a measuring tape next to it. It's kind of hard to tell from the picture. But you want to be able to describe what you see. For wound drainage, you want to note the amount, the color, the odor, and consistency. If it has no odor, you can just say no odor. But if it has an odor, foul smelling odor, sweet smelling odor, if you have a wound that has like a urine smelling odor, you say that it smells. If you have had an abdominal wound that it smelled like urine was coming out of the abdominal wound, and sure enough, there was urine coming out of the abdominal wound because they had perforated her bladder. Urine that was in her abdominal cavity that was coming out of her dehiscing abdominal wound. So it made sense that she had drainage out of her abdominal wound that smelled like urine. The rest of it was also a really gross yellowy green color, but so describe it. How much? You know, copious amounts, minimal, scant. Get really good with your adjectives. Wound closures. We have stainless steel staples, nylon sutures, silk sutures, absorbable sutures. Those you'll find, like if they've gone to OR, you'll find that information generally in the OR, the opt-out. That'll give you the specific types of closure. Dermabond, that's our fancy, just glue. We glued you closed, you're good to go. Dissolves on its own. You want to make sure you tell your patients to not try to pull it off yourself. It will dissolve when it's if there is a problem with the wound, we want cultures. However, they're not 100% reliable. So you may also be getting blood cultures on your patient. You also do not ever want to pull cultures off of the bandage. It needs to be from the actual wound. The wound bed is best. And the reason why they're not 100% reliable is because it could be bacteria that is just out there on us. That's why we want to make sure we're getting in the wound as opposed to just topically on the wound. And really a tissue biopsy is going to be a gold standard if they're very concerned about what they're fighting. And you may have that happen if you have a patient who has a pretty consistent wound they can't get healed. So for nursing priorities, we have risk for infection, impaired tissue integrity, acute or chronic pain, imbalanced nutrition. This one, keep in mind, it's something very, very important. You can have an obese patient who has imbalanced nutrition, less than body requirements. How can we tell that? What do we look at? Labs, absolutely. Which ones? Which lab? It's not just labs. Which ones?
It's like sodium, potassium.
Those are electrolytes. So which there's. So if we're looking for imbalanced nutrition, which labs we want to look at the most? Protein. What else would also? Huh?
LDL.
So that's cholesterol. So protein and albumin are going to give us our best overall vision of what our patient is looking like when it comes to nutrition. So protein and albumin. Impaired skin integrity, that's always gonna be our best bet. When you have have skin issues. Impaired mobility, especially for your patient who has has some sort of like, pressure ulcer. And then ineffective tissue perfusion and risk for impaired skin integrity. If you have somebody who is immobile, but doesn't have skin breakdown yet. For outcomes, remember the patient will. And then for wound improvement, what does that look like? What does wound improvement look like? Patient will have, we'll have a healing wound by the end of my shift today. Well, how does that's pretty fast, right? Patient will have no further skin breakdown in any location. Will have a 10% increase in caloric intake. So increased protein consumption. Think about when you're talking about outcomes, how can you impact those outcomes? If I say increased protein consumption, what can I do to impact that? Well, consult dietary, talk to my patient about having those really yummy protein drinks, right? So think about the things that you're going to be able to do to impact those outcomes. This is a great care plan to go over. Diagnosis, the patho is another patho that's not in the right format though, so. But it's regarding a patient who's had a total hysterectomy with a bladder sling, so kind of has some good information for you. So when you're looking at plan of care, make sure you're looking at interventions to promote improved skin integrity or wound healing or both. How to bring in other folks to help enhance treatment or care, and then make sure that you're always involving patient and family when it comes to interventions. Interventions can include specialty mattresses, adjuncts like foam or air-filled cells. There's the air fluidized beds that do the fancy stuff whenever they move. And then there is the rotational beds, depending on how sick that patient is. This is the preventative interventions to maintain skin integrity. So there's like a check mark on all the different things we could do. Or to kind of help you along with ensuring that you're doing good things. When it comes to management of skin ulcers, we always want to use a holistic approach. Reassess the wound often. This is not a one and done. This is every shift at least, if not more, depending on how bad that wound is. We want to work to prevent and manage infection, clean the wound, debride and remove any non-viable tissue, manage any exudate. That's going to help to maintain to keep moisture away and protect the wound. For dressings, we have bandages and cloths depending on what you're dealing with. Cover and immobilize whenever necessary. Do not remove any sort of penetrating object. Got a screwdriver in the head here. I think that's probably some nice imaging of that patient. Dressings are meant to protect a wound from microorganism contamination, to help with hemostasis, and to promote healing, depending on the type of wound. Patients may also not want to see the wound. And for little kids, they're seen as magical healing properties, especially if you add, moms can add a little kiss, moms and dads can add a little kiss to Band-Aids, and they instantly heal, even if there's nothing underneath that Band-Aid. There's different types of dressings, dry and moist. That's generally with gauze. If you hadn't seen one before, this is, Metholex. They're amazing. They're, like padded and they have all sorts of wonderful properties to them. So that's particularly on, staple, area. So we also have, the film dressing, that's also your Tegaderm. Hydrocolloidal protects the wound from surface contamination. Hydrogel maintains a moist surface. To support healing, so there are times when we do want moisture on the wound itself, because if wounds get dry, then they end up actually causing more breakdown. And then we have vacuum assisted closure that uses negative pressure to support healing. They're absolutely phenomenal. They're actually causing increased blood flow to the area and are amazing. It does require a constant vacuum seal. They are incredibly painful dressing changes. You have wound care coming to do a dressing change for a wound vac. Make sure that your patients are nicely medicated. They have to be changed anywhere from every 24 hours to 5 days, depending on the wound. But they are phenomenal. Here is the wound before wound care. Did wound vac and after. And it is absolutely amazing the care that does. When it comes to dressing changes,
Let's go backward.
what's that?
How does it work? What does it do?
How does it work? So it is taking, and it is because it's using essentially suction. So this, it's packed with a, I don't know the type of, it's a foam. And it is essentially utilizing suction to bring more, like circulation to the wound itself. And this is all like a Tegaderm all around it. And it sucks out all of the nasty wound contents. I'm trying to, because in the vacuum, there's a canister, so it has blood and it'll have exudate and all of that with it. That's why it depends on how often it's changed. And it all gets pulled from the wound. And so it's providing healing from the bed of the wound out.
It sits in the.
It sits in the wound. It is packed in there. So if it's like, I mean, in the case of this one, it would have been packed up underneath all of those areas because it needs to create a suction there. So it would have been packed up underneath all of those like shelved areas when you guys did lab, when it had like those shelved areas and stuff. It would have been packed up in there and then it's laid on top, and then it's like a Tegaderm, heavy duty Tegaderm goes on top of it. And then it just sucks away. And it sounds like a, it actually kind of sounds like an oxygen machine, where it's the in and out kind of sound. And generally is on for, I mean, it's on all the time minus the wound changes, but then they have them anywhere from 2 weeks to months. My aunt had a really bad wound in her armpit that she had for 8 weeks, having a wound packed in, and it saved her life. Otherwise, she probably would have died from sepsis. So the advancement that we've had with wound vacs is phenomenal. So wound ostomy, if you're interested in wounds at all, the stuff that they get to play with is phenomenal. So, okay, when it comes to dressing changes, pre-medicate whenever necessary for your patient. dressing changes are, can be very painful, especially when you're talking about having to do a dressing change on something like that. Or if a burn patient, want to gather all your supplies, assess the skin, and then hand hygiene all the time. So you're about to put your hands into something that potentially needs to have sterile, a sterile dressing change. Depending on the wound, will depend on whether or not it needs to have a sterile dressing change. If I am changing a Band-Aid on a patient because they bumped their arm, I will make that a clean dressing change. I'm not gonna make that a sterile dressing change. That is a nursing discretion. But this, as a wound vac, the initial process of getting all of that set up is a sterile dressing. That I'm not shoving my hands into that and not having that be sterile. So it depends on what you are doing as to whether or not it's a sterile dressing. Penrose drain. This is a drain that is placed surgically. And then usually has like a pin or a clip of some nature. In this case, they show up with a super fancy safety pin to prevent it from moving further down into the wound. Are you seeing Penrose drains? I've seen a couple. It's usually like cervical kind of. Yeah. Okay. So say usually you'll see Jackson Pratt drains or JP drains. We jokingly refer to them as hand grenades. That's what they look like. In order for them to work, you actually have to press it all the way, then you close it. And versus or CNAs can empty them. And then you obviously to check how much they drain, pop the top, squeeze out, because they'll fill up as they're draining. You have this little collection hand grenade of blood or serosanguinous fluid. Then you pop it, drain it out, squeeze it back down, close it again. This is a hemovac. And it, in order for it to be able to suction out, it has to be squeezed flat. And then it will fill up as it is evacuating. So cleaning the skin, you want to make sure you're cleaning from the least contaminated area out. And then when irrigating away from the least contaminated area. So for example, they have the Jackson Pratt here, so we're circulating out from that. Or if you're on an incision, doing everything away from the incision. We go down the incision and out. Irrigating from the inside out or from the very top down. So you're irrigating away from that. For wound debridement, this is removal of non-viable or necrotic tissue. We can do this with burns. We can do this with patients that have a severe ulcer. You can also do this if there's a really bad infection and we're just trying to get off as much as possible. So it helps to enable the visualization of the wound bed to see what exactly is there. Are we like underneath this heel, are we actually seeing bone and muscle and tendon, or is it flesh under there? Is it viable flesh? The body can't heal with this rough eschar here. It can't do anything with that. It's non-viable, so it's got to get it off. Also, depending on the size, the patient may go to the OR so that they can do that under sedation because it's painful. You do not want somebody just chopping off your heel with no sedation or good pain. Okay, suture removal. Be sure you know the policies and procedures where you work. If you have been trained which you have, nurses can remove sutures and staples. Y'all have learned how to do that. You know how to do that. You can remove it, but you're still gonna look for signs and symptoms of infection when you do that. And ensure that everything is good. And then when it comes to evaluation, how does the skin look? Do the pressure, friction, shear, moisture components, have we eliminated those to the best of our ability? Did our plan of care decrease contribution of each of these components, and has the patient either maintained or done better since we implemented those? And then was wound healing supported by providing a wound base that was moist and protected? So do we have a wound that needed moisture in order to heal versus staying dry so we don't get a wound? And then were issues such as nutrition assessed and plan of care developed that provide the patient with calories to support this healing? Okay, questions, comments, concerns?
So since you're not gonna be here with us anymore, are your tests gonna be the same setup?
They should be pretty close.
Okay, but it's not gonna be you create.
Well, so the questions were already in the test bank,
Okay.
and the only thing that I modified was because I changed our helpful outline a little bit. And so I had to pull some questions out. And I've already emailed Dr. Persons and Professor Rafi Bayless to say, here's the questions that I pulled out that need to go on the next exam. And so they're aware of that. And then I added the math questions, which is part of our thing we're doing anyways. So they know that part as well. So they shouldn't change by much. It should be pretty close. Yeah. There.
Okay, so I was thinking, like, there's only so many positions that you can put a patient in, especially if they have certain.
Oh, you do some questions.
Okay, so because I was thinking about
Which is actually inevitable.
So
It's there for a prolonged period.
no, that is a great question, and not to make light of it, but yeah, there are some cases. So think about your very sick ICU patient who has like a really bad traumatic head injury, and anytime you move them, their intracranial pressure goes sky high, and you're just like, I touch them and they. And obviously I don't want the super high intracranial pressure because that's gonna kill them faster than a buttock, right? And it's those times that you have to balance one priority over another. And so in that case, it's, well, am I going to just barely tilt them off their sides or off their back and get them at a 10-degree angle because that's all he can tolerate? And I'm gonna do that for 4 hours instead of changing every 2, and that's what I'm gonna document. And that's what we're documenting, that patient's ICP does not tolerate excessive.
Also, like, no, it's actually not these are very like. So like. Sorry.
No, that you're asking questions that are prompting like the idea of putting your critical thinking to it. Like, well, what do you do when?
Like, if it's so small and it has all those things attached to it, then how do you prove it? Like, I've never heard of nurses or any dental staff moving babies, especially if they're like a little, you know.
Those are also the ones that are highly impacted by excessive moving animals. They'll desat, they'll break you down, they will So it's a matter of, well, which is better? Is it them? Is it me keeping them alive versus them developing pressures there that I covered?
Okay, last question.
Yeah.